Hello, my name is Dr. Skip Rizzo, and I'm going to present today on the intersection between psychedelic therapy and clinical virtual reality. What I'll try to accomplish in the next 30 minutes will be to present a brief introduction to virtual reality and talk about the detailed ways in which it's been applied clinically across a wide range of clinical conditions. Then, in the second half of the talk, I'll cover its integration with psychedelic therapy and my proposal for a clinical model to help guide its clinical application as well as the research that's needed to advance this area. I'm going to try not to be redundant with the great speakers that have already presented on psychedelic therapy and really try to give you an honest appraisal of how I see this field evolving in the future. With that said, I do have to mention conflict of interest. I am a founder, along with a number of other folks, in a company called Virtual Psychedelics. Although the bulk of this talk will focus on the work that I've done over the last 25 years at the University of Southern California Institute for Creative Technologies within the Medical Virtual Reality Lab. I'll make it very clear when I talk about the virtual psychedelics work so that there will be no perception of a conflict. Over the last 25 years, we've developed applications in the clinical sphere addressing psychological issues, cognitive assessment and rehab, physical and occupational therapy, and the use of virtual humans for clinical applications. And I'm going to wheel through a couple of examples of each of these areas to sort of set the stage for how virtual reality can be applied in these areas. So with that said, in the psychological domain, here's an example of a virtual reality simulation that we've developed and implemented treating post-traumatic stress disorder, applying an exposure therapy approach. This is what it looked like in 2008. But in this case, what we did was to take the application developed for exposure therapy for treating PTSD and use it as a tool for cognitive assessment. So the user immersed in this environment could be tested on attention, memory, executive function, and so forth. We don't just do military work, obviously. This is from 1996, an early 3D projection system for testing and training mental rotation abilities. This application, this is, I think, from 2003 or so. And this is what a child sees in a head-mounted display in a virtual classroom, and it was designed as an assessment tool for testing attention processes. So child has to pay attention to stimuli on the board, but meanwhile distractions appear, like the teacher answering the door, or the kid in the back throwing a paper airplane, or a school bus going by the window, and a variety of other distractors, but basically a methodology for creating a controlled stimulus environment within a functionally relevant world for testing complexities of processing in clinical populations like kids with ADHD. In the area of physical and occupational therapy, I'm not going to spend too much time on it. I'm not so sure this is relevant in this space, but this is an application we developed that uses the Microsoft Kinect to track users' body movement and embed that body movement in an avatar in a game-based simulation for testing and training the very boring, repetitive, and frustrating work of physical and occupational therapy. Try to help people to do more of it by making it maybe a little bit more fun and engaging, and quantifying their performance while they're in these simulations to give them feedback on how they're improving. We've taken the same technology and used it a little bit differently. In this case, with children that have cerebral palsy. And so the Cerebral Palsy Foundation wanted us to just simply make it so that children who have severe motor impairments could play video games. These kids often don't have the learning and ability to use a gamepad or keyboard. So what we did was we tracked the movement that they were capable of volitional controlling, and use that as the audio communicator. So lifting her arm like this makes the shark come out of the water, and she can do something she's never done before in her life. In the area of virtual humans, we've done quite a bit of work in this space. The first instantiation you'll see here is a virtual patient. And this is, I think this one is from around 2012. It's evolved quite a bit since then. But this shows a novice social worker in training practicing a clinical interview with a patient who may be at risk for suicide.
Good afternoon, Sergeant Castilla. What brings you in?
Well, my wife told me she thought I should talk to someone. She's been pretty concerned about me since a soldier suicided on base last week.
Did you happen to know the soldier?
Yes. He wasn't a friend, but I met the Marine once or twice. He seemed normal at the time. I guess I'm afraid I might end up like him.
Do you have any plans to hurt yourself?
No. It certainly crossed my mind, especially lately. I just need it all to stop. Sometimes I can't handle it.
So I like to say that this kind of an application gives novice clinicians a chance to basically screw up a bunch with a virtual patient before they get their hands on a live one. I think that's really kind of good experiential training for clinicians. Finally, this character was a person we built for a virtual agent that we built for online delivery of healthcare information for service members, veterans, and their families. The user could engage in a private, anonymous way with this guy. Bill Ford was his name, and get information about PTSD and traumatic brain injury and so forth, other wounds of war. And meanwhile, he could ask questions that were thinly veiled screening questions for some of these clinical conditions. And at some point, the user answered affirmatively and reached a certain threshold, the character might break into the mode of saying, hey, it looks like you're having some trouble. If you want, you can punch in your zip code at the bottom here, and I'll pop up a list of providers in your area. And if you'd like, I can answer questions about what therapy would involve. So it's not a replacement for good clinical care. It's not a virtual therapist. It's a guide to help break down barriers to care. And so let me let him introduce himself here.
Well, I'm not a real person, if that's what you're asking, but I'm based on the personality and experiences of real soldiers and Marines. I'm still just a piece of software, but I'm getting better all the time, so hopefully I can be a helpful piece of software to talk to.
Okay, with all that, let's take a step back and talk about definitions. So from a technocentric position, you can say that virtual reality is a collection of enabling technologies: computers, display technologies, interface devices, computer graphics, and so forth, all with the aim of putting a person in a simulation for a specific purpose. I prefer the more human-centric definition, which really is about basic human-computer interaction, ways that we can help people to interact with computers and complex data in a more natural and intuitive fashion. And if what we see over the last 30 years or so with human-computer interaction is any indicator, perhaps it's time we moved in this direction beyond just simply hunting and pecking on a keyboard. The best metaphor for mental health and rehab with VR is aviation simulation. So just as an aircraft simulator would serve to test and train piloting ability, we can test, train, teach, and treat psych, cognitive, and motor functioning, all within a controlled stimulus environment, basically the ultimate Skinner box. Now there's 3 I's in virtual reality. And these 3 I's are things that kind of guide us as to how we can use it and develop applications. You don't always need all 3, but you need typically at least 2 of these. So when we talk about immersion, well, that's putting somebody in a display, like a head-mounted display, where their body movement and turning updates to graphics that are presented within the display. The simulated environment, in this case, an Afghan marketplace for the PTSD work. We can also do it for physical therapy. This application is where we put a sensor on the headset, it tracks the hand movement, embeds it within the user's view, and they can interact with 3D graphic content within virtual environments. And we've applied this for upper extremity and hand rehabilitation after a stroke or traumatic brain injury, as you see how that operates. Now, It doesn't always have to be immersive. In this case, this is a balance training exercise that we developed. Imagine an elderly person with a safety harness shifting her weight side to side and driving this penguin down a ski slope. She could lean forward to speed up, lean back to slow down, and a safe way to practice balance skills, but in an engaging format. And it doesn't need to be immersive, although it certainly could be. It doesn't always have to be on a large screen. If you make compelling content that's imaginative, people will engage with it. And we can also deliver virtual human interaction without having to use a head-mounted display, although this application can run in a headset as well. We typically deliver it on a TV. And basically, this is a job interview training system we developed with the Dan Marino Foundation to help people on the high end of the autism spectrum move forward in life by being able to survive a job interview. These folks are often very intelligent, very capable, can do the job, but they have difficulty with social interaction. So we built out this system with multiple characters, a different age, gender, ethnic background, different backdrops, and each character can be set at 3 levels of provocativeness: soft touch, neutral, and cranky. So here's an example of this character, this backdrop in the soft touch mode.
I'm glad you're here. In a minute, we'll get into some questions about the job. But before we do, why don't you just tell me about yourself?
Okay, so we could make her neutral or cranky as well, or we can pick a different character and a different backdrop.
This is an entry-level position. I guarantee there will be things you won't like about this job. That said, what's the most important thing you think you're looking for in a job?
Okay, so when we look at the field over the years, virtual reality really got its traction clinically with specific phobias in 1994, and it's evolved quite a bit since then. But on the right-hand side is a short list of the areas where VR has been applied clinically and in research, where it's documented added value. And I'm happy to say that not only has the technology improved and gotten better and caught up with the vision from back in the 90s, but the scientific research has evolved as well. And I can make the case that we have probably the largest scientific literature of any use case for virtual reality in mental health and rehab. So a lot of reasons why people got excited about this vision early on. We're not going to go into all these in detail, but I can make this paper available, which does go into detail. So send me an email if you'd like it. But we can distill it down to 5 core components: expose, distract, motivate, measure, and engage. So we can expose people to things they're fearful of or that they've been traumatized by, but in a safe, graduated fashion. So for PTSD, exposure therapy, combat related, we can do things. And we can also address more mundane issues with anxiety, like public speaking.
These results are promising. What impact do you think it may have in the future?
And the goal here is to help people confront and reprocess difficult emotional experiences or to overcome their fears. And the research in this area is pretty solid. This came out in 2019, where essentially it reviewed all the literature in the anxiety disorders field and basically, makes the case that VR is an evidence-based approach in this area. For the PTSD area, we've published a number of studies, and also independent collaborations have documented its value. When used in a graduated fashion with a well-trained clinician, we see significant benefits for our clients.
I mean, am I 100% better? No, I wouldn't say I was 100% better, but I do have my life back. I'm able to do a lot of the things that I did before. I don't have so many issues. I'm not running around angry all the time. And this treatment was, it saved my life probably. It saved my marriage for sure. So I would say if you ask me if it works, yeah, it works.
Now, distract is more about pain management, particularly acute pain management. So here's an application where it was designed for, say, somebody in a bed wearing a VR headset and playing this game while they're getting a difficult and painful medical procedure, like pouring the care and so forth. And the user is distracted away from the painful experience. And again, the literature is pretty solid in this area. Solid 20 years of research has documented the added value for using VR as a way to
After just
express
5
people.
sessions, he says his pain disappeared.
The cost to me was really minimum, just a little bit of time and no side effects.
Dr. Sean Mackey, one of the nation's top pain experts, says the treatment works by tricking the brain.
And that's where the excitement for VR comes in, is the opportunity to rewire our brains into a more normal state so that we're not experiencing as much pain.
Is this the future of pain management?
I think it's one of the critical futures of pain management.
Oh, yes.
For patients like Pierre, the future is already here.
So that's an approach for treating chronic pain, which is now emerging as a possible use case for virtual reality. Motivate, this is a stroke patient interacting in a game-like context, and if you watch his red ball, you'll see exactly what we're trying to do here, get people to put that extra push in there. And again, the literature is pretty solid in this area. A lot of randomized controlled trials and meta-analyses of these trials indicating positive benefits and low-cost systems like what you see down below that can make this treatment accessible to many individuals that can benefit from it. Measurement.
I feel like I'm in on the cutting edge, and that is very exciting.
Sorry about that. I forgot I had that in there. That's one of our first stroke patients using some of our work. Now measurement, again, virtual classroom, but the more modern version of it. But there's many of these types of applications, controlled stimulus environments where you can measure performance under a range of controllable conditions. And the research, again, has been quite favorable in this area. Finally, engage. This is part of what people say is the magic of VR. We can engage people in things that they might not ordinarily want to do. Learning mindfulness is very time consuming. You don't get the effect right away in traditional methods, but doing it in VR, you may engage people in contexts that might be helpful in this area. Now, we've shown related to engagement preference, when we asked service members and veterans if they had a choice between VR exposure or traditional imaginal exposure, 76.7% would have picked VR exposure. This was part of a randomized controlled trial. They really didn't have a choice. We also
how's it going?
Have virtual patients.
I'm good. Look, this is my wife's idea.
This is an application that we published research on showing that clinicians engage with virtual patients like real patients to the point where they get benefits in how they learn to do motivational interviewing, and that those benefits transfer to the real world. All these papers are available. Send me an email and I'll forward them on to you. Also, back to the autism application, here's a user talking about her experience. Folks on the spectrum often have difficulty in social interaction, but she had a little bit different response when interacting with a virtual agent.
It's a good program, and it teaches you how to do an interview, and it teaches you how to be in an interview situation with another person.
And did you see your performance improve? Did you get better?
I get better every single time I do it. I get better.
And to the right is some of that data to show some of that performance improvement over time and translation or transfer of training to the real world. So, virtual psychedelic therapy, the second half of the talk. Well, we're not the first person to ever think about this. I mean, it just makes a lot of sense. And I recommend this paper highly. It really talks a little bit about some of the reasons why. It doesn't present the clinical model that I'm going to present next, but it makes a case that both psychedelic drugs and VR can be used to disrupt the rigidity of a sensory experience. And, the research is showing that both therapies have a lot of encouraging evidence. So can we bring them together to craft an experience for the user while they're experiencing a psychedelic experience in a therapy context? Now, again, other people have thought of this too. There's a company that's using spherical video for this purpose with ketamine, and I'll show a little clip of what that looks like.
I think what we've seen over the last few years that we've been doing this is that the ketamine suspends that a little bit. It takes you away, dissociates you from this false false autobiographical loop that you have going on in your mind, and it allows you to kind of take yourself into a better space and hopefully, remodel your own mind and get to the point where you start replacing that false narrative with a better and more positive narrative. Now, what we want to do is to augment this. We want to really supplement this process and improve on it by using virtual reality and having the guided meditations as you're working through that. So what we call this is virtual dissociative remodeling, VDR. And it's pretty exciting. The people that we've beta tested it on have given us some really good positive feedback about how it's working.
So I'm looking forward to seeing some research on this topic. But what I'm going to present is a model that might be useful for how we apply VR in cases that specifically target psychedelic therapy across a wide spectrum of clinical conditions. Now, we know both approaches have a growing body of evidence supportive of its clinical usage, but that doesn't ensure that just simply by throwing the two together, you're going to get some additive value. We always have to, of course, pay attention to patient safety and well-being. That has to be at the forefront. And to do that, I think we need to say when VR may be appropriate for crafting an experience and when it's not going to be appropriate, and how to customize it to the needs and the therapy goals of your patient or client. It's not something you're going to use in a whole session, a whole bunch of time. Our model proposes that strategic use at critical junctures may be useful, and maybe prior to a psychedelic session, setting, of course, preparing somebody for what they can expect when they go into this type of treatment, as well as crafting an experience at strategic junctures. Perhaps the person is very anxious in the beginning, perhaps a calming application might be useful. Perhaps at a later point, a more reflective or engaging application, as you'll see in a minute here. So a lot of ways to do this. There's not a one size fits all. And maybe there's some things you can do in VR during the therapy session that when you give a headset, and these headsets are very cheap now, standalone headsets are like $300, they don't even require a computer. They can take that home and maybe do some follow-up therapy with this application that draws from what they experienced in the psychedelic session and promote generalization. We're not talking about recreational psychedelic use here. I'm sure everybody gets that. I don't need to say it. But a clinical model is needed for understanding how VR can be usefully applied. And that's what I'm going to cover right now. I think it's essential to have an organized structure for how you think about this stuff to promote enduring positive mental health outcomes. I think clinicians that understand this model may be able to know when they can strategically apply VR and get the positive benefit that the combination may provide. The first step, of course, is a clearly defined diagnostic target, something that may rely on evidence-based approach or a frankly experimental approach that creates an experience for the user or helps them to create one for themselves. So the model is evolving, but these are the 5 core elements of it that map to virtual reality. And I'm going to go through each one really quick here. So the activity level of the user, of course, you can give them games where they're going to be, playing physically, but this is on one end of a continuum of more extreme action, probably not likely in a therapy session. But on the other side of the spectrum is very calming passive activities where the user doesn't have to really do a lot of action. They can experience things in different ways that help provide an experience that might be useful. The second element of the model is the content. Realism versus surrealism. And I picked the two opposite ends of the spectrums as illustrations, Google Earth and the Dreams of Dali application that was originally built for the Dali Museum, where you can go into a Dali painting and interact within it in VR, as opposed to interacting anywhere on the planet through the Google Earth VR application. We can also do things with nature. So on the left is an actual spherical video of a pod of dolphins. It was developed by the Dolphin Swim Club, used in pain management and a number of other clinical areas. And on the right, you see 3D graphics of an underwater scene. This also is 3D graphics for this application called the Blue. And there's a lot of advantages to both. It's just a matter of understanding what is going to be more appealing and useful for your client. Sensory predominant. You can have virtual environments with no sound or ambient sound, very basic ambient sound, and that may be sufficient or desirable when somebody's going through psychedelic experience, or you go with
Welcome to Magic Horizons. Breathe and relax. You are here in a safe location, enjoying a wonderful relaxation experience.
Guided imagery, binaural beat audio
now,
brought to bear in this.
Please
as well
pay attention to your breathing. Breathe easily.
Whether the environment is social or private. On the right, you can foster very solitary experiences in virtual spaces that are designed to promote self-reflection and have various activities that are designed to do that. However, you can also do activities that involve virtual humans. In this case, real-time avatars of real people, whether it's a clinician or somebody else that the person wants to communicate with, but in a novel environment. Now, that is certainly sort of cartoonish, but this is some of the basic level stuff. You can have applications where the realism of the characters are also quite high. And these characters, again, are driven by real people interacting with the person in the virtual space. And I think there's a lot of creative opportunities there for doing that sort of work, whether it's a cathartic interaction with an archetypic person or practicing your social skills with a member of the opposite or same sex that you want to communicate with. You can also do virtual humans that have some level of artificial intelligence that don't require another person. And you know, we've developed some of that for clinical interviewing, as you can see with this character.
Hi, I'm Ellie. Thanks for coming in today. I was created to talk to people in a safe and secure environment. I'm not a therapist, but I'm here to learn about people and would love to learn about you. I'll ask a few questions to get us started. And please feel free to tell me anything. Your answers are totally confidential. Are you okay with this?
Now, some people might think that's creepy, but actually we found that with some users, they feel a comfort talking to a virtual human because they can say what they want, they can engage in a conversation. It's fairly credible, but with no risk of judgment or shame. And we've documented this in our research. People self-report more psychological symptoms than they would on a checklist or a clinical interview with a real person. They self-disclose more personal information and so forth. So this may be another area worth looking at to promote the experiences people have in a psychedelic therapeutic context. You can have very calming environments. Again, very similar to some of the points before, but a little bit different, because here we're talking about activating somebody in a directive way. And, you know, this may be at odds with some folks' view of how the psychedelic experience should be conducted in therapeutic context, but there may be a value in helping people to confront things that they're fearful of or that they're having difficulty with. They're flying in this case. You know, areas where we've documented that ER does have some value. This simulation on the left is actually part of a sexual trauma exposure therapy application that has shown good clinical outcomes, clinically meaningful, and statistically significant improvements in PTSD. So with that, let me close with a couple of final points. How do you do this? Well, you can use in a therapeutic context, standard low-cost standalone headsets like this one here, the Oculus Quest, but there are a number of these out there now. And very low cost and very easy to use. On the right, the area I mentioned with my conflict of interest statement, working with virtual psychedelics, we're looking at building, and we've gotten some investment in building pods. The user doesn't have to wear a headset. They can be in a comfortable space and have the display around them and have sensory inputs and also track biomarkers, heart rate, skin conductance, build in perhaps a biofeedback element into the mix to help people calm themselves or focus their attention on something. Virtual patients for training psychedelic therapists. Psychedelic therapy is a high art, and if we're going to roll this out in a large scale method or fashion, training clinicians is very difficult. At least get them on training wheels practicing for provocative events in the course of how a therapeutic session might be conducted. So that's one option. It's everything I've talked about here is therapeutic perspective agnostic. Whatever your clinical direction is, there may be an application for VR if thought about in a considerate manner where you consider what it brings to bear in crafting an experience for a user. Let's stick to the science, okay? It's not magic here. Sometimes it feels like magic, and some people in VR and in psychedelic experiences may report that, but we've got to hang with the science here. We're in the midst of a renaissance of acceptance and excitement. Let's not mess it up. And this article that came out last year, Yaden and Griffins, I think really talks as a cautionary tale about what we need to be careful about in order to make this a real reality as we move into the future. So in conclusion, I'd just like to mention that, the expose, distract, motivate, measure, engage model, I think is a useful approach to think about VR, but it can get way more detailed, and feel free to send me an email requesting a paper. As well, we can make the case with VR that it's theoretically informed, scientifically supported in clinical use cases. We have a low-cost, high-fidelity technology available now. That's no longer a barrier. Passionate development community. And I think most of these elements are very similar to the psychedelic domain now. There's some theory being involved. We've got scientific support, a passionate development community, maybe not low-cost, high-fidelity technology, but we have legal capability to do this. And I hope we can do it well as we move forward into the future. So with that, thank you for your time and attention. Thank you to the organizers of this great event and the talks that have gone on here. I'm really looking forward to being able to answer questions. So thank you very much.